welcome everyone to Greater Living. I'm Mary Beth Marsden. Thank you so much for joining us today. I think we have such an important topic to discuss, and I think you guys all agree because our house is packed and we've had very active participation on Facebook Live right now, and we're trying to answer so many questions involved with caring for an older relative, caring for yourself if you're elderly, or you have some health issues that prevent you from living independently, all kinds of things we're talking about today. So joining us right now is Beverly Ruiz, who is the team leader of the Elder Medical Care at GBMC of the program. Bev, thank you so much for being here. And Leanna Hoover, who's the director of Elder Medical Care at Gilchrist Elder Medical Care. And we just heard a lot about from Danny about taking care of elderly relatives, loved ones, or yourself in the home, sort of an independent contractor, as it were. You kind of are another layer of that, particularly for individuals who need more medical attention. They kind of come to you, and people who want to be back in the home and want to kind of have some say over maybe even end-of-life issues. So thank you both so much for being with us.
Thank you.
And there's a lot of terms we'll be throwing around over the next hour. Many of them you're familiar with: hospice, palliative care. But really, if you were to ask the average person on the street, I think, what is elder care? What is palliative care really? What's the differences between them? It's still really confusing for a lot of people, I think. So we're going to be focusing right now for this section on elder care and what your group does. So let's just kind of big, broad talk about what it is. Either one of you can jump in.
I'm going to actually ask Bev to describe the work that she does.
So our program is physician and nurse practitioner, social worker based, and we provide primary care in the home. We service patients who are primarily home restricted. They can't get out to get the medical care that they need in an office, and so we bring that care to them in the home.
Can you give us a scenario? So they've gotten to a point now, probably, the patient or the individual, where they realize they need medical care and they can't get into a doctor's office, or they have the type of issue where it can be cared for at home, right? Some patients can't, right? I would assume, depending on what their issues are. So that's the point that you're called in.
Correct, and this may also be patients who have health crises. They have chronic medical conditions with frequent health crises, and if you can't get out to get the care that you need, then you often fall into this cycle of hospital, rehab, home, hospital, rehab, home. And so part of the purpose of the program is to break that cycle, bring that care into the home, and then intervene before that patient ends up back into the hospital, into the system that way.
Yeah, Leanna, I know we often hear, and I think we all are aware that in this day and age, it's the general school of thought that if you can get out of the hospital and get back home and still get the care you need, that's usually preferred. Is that still what we think?
Yeah, absolutely. I think the setting is more conducive for people actually healing. Caregivers can be there, and the service that we're able to provide brings the provider, as Bev said, to the home and to the bedside, and we become part of their team, and their family becomes much more engaged, and I think has ownership also in participating with that disease management.
So when you're brought in to being part of the team, what do you look at? What kind of criteria are you looking for to see if this is actually the way forward?
So our patients, we are serving a homebound or home-restricted patient. So, our feeling is still if you can get out to the doctor or to your nurse practitioner in the office and have those needs met there, have that work completed in the office, that's still your best bet. But for our patients who can't get out, who have chronic life-threatening illnesses, who might be dealing with end-stage cancer or a terminal diagnosis, those for which maybe medical treatment is no longer effective, that is the appropriate patient for our program.
So we're not just talking about transportation issues here?
No.
Right, so they really physically just can't move
Correct.
at this point, and they want to be home. At what point does your referral come into play? How do loved ones find out about you? Is the doctor the one? What's the next step? How does that work? I'm assuming that you usually come into the picture during or after a hospital stay.
I would say it depends. So it's across the board. Sometimes it's a hospital stay where patients had an acute issue and the provider or the social worker or case manager at the hospital is able to make a referral. Sometimes it's a patient who goes to see their physician at the office, and the office notices, hey, we haven't seen Mr. Jones in about 6 months or so, and makes a phone call and realizes a significant change has happened. And the family and the patient's just no longer able to come in, and so the physician might make a referral to our group directly that way.
And then you go and you assess the situation and decide what's needed. Now, when we talk about what's needed, what can you provide? Is it one day a week? Is it every day? I'm gathering it depends on the patient's needs.
Certainly, and we like to stay in contact with our patients and see them on a regular basis to stay in touch with those small changes. If we can intervene in some way that we can prevent an emergency room visit, that's always the best outcome for everyone. We are different from a skilled home health agency, which might provide nursing or physical therapy or occupational therapy, home health aid, where they may be making frequent visits through the course of the week. Our visit schedule depends on what the patient needs at that point and what the medical need is for the provider.
What have you seen, and I guess this would be more to what you do, what have you seen with regards to the patients in their emotional well-being, in how they respond to treatment because they're at home?
I think the outcome is always better when you're in your own environment, and it allows us to really see the difference of what family can provide and what support is needed. Or, when a patient's in their home and they've left the doctor's office or the hospital and they're sent home with, prescriptions and instructions and do this, do that, and then they get home and they think, how am I supposed to make this happen? We're there. We're in the home with that patient and that family, and we can really see what's going to work and what's not going to work.
So it's kind of like, don't worry, we got this. Which brings us to the family. I'm sure there's all kinds of different personalities, different situations that you don't know what kind of you're dealing with. You see this one patient one time maybe in the hospital, but everything is very different when the whole community becomes involved or the whole dynamic of the home. So you must have to sort of treat, as it were, the whole family.
Yes, sometimes, as we know too, the picture that we have of a person going home can be very different upon the arrival. As Bev talked about, when you go in, sometimes a person is challenged even to get their own medications. So even though they had the order, we realize that the medications aren't there, or what we thought might be needed for durable medical equipment, we really need either a different type of a bed or something to help them in the bathroom. Or we thought that the family thought they might be able to assist them more than they truly were. So then we're, again, looking at other people and partnerships that can help us.
So I think this is a perfect time to talk about what this really means for the patient to be in the home, to be under your care. And recently, our colleague Don Scott sat down with you, Bev, and one of your patients to talk about what this program meant for them, what they were facing. And let's just take a listen to that.
Older individuals living with serious illnesses often find themselves in an unending cycle of back and forth visits to the hospital, doctors, and rehab facilities. As you can imagine, this can be very difficult for those who require extra assistance. That's where Gilchrist Elder Care Program steps in, designed to take away that burden, ensuring that people receive the care they need when and where they need it. Nurse practitioner Beverly Ruiz took us to the home of patient Darlene to get a first-hand look at the impact this program is having.
I'm interested in knowing what your condition is and how you got there. What happened to you?
Back in February, February 9th, 2017, I had some symptoms that I didn't know was a stroke. I was trying to make steps, and my left foot, I could not figure out how to walk with this leg and that foot. So about 12 hours later, I could not stand up on it any longer. It just wouldn't hold me. So they admitted me, and they did the MRI, and when they did that, they found out that I did have a stroke. So fortunately, and like I said, when I got Beverly and Gilchrist, everything for this stroke and what I have to go through with it has absolutely changed.
So besides the paperwork, is she actually your physician?
She's my primary care physician, yes.
She takes your blood pressure and...
She does everything.
Can you imagine what life would be like without Gilchrist?
I don't know where I would be today if it was not for Gilchrist and Beverly and what they have done for me. I know there's so many other things, but like I said, without them, I do not know where I would be. I don't know what we would have done. Anytime you call there, like I said, they're just there to help you, to get you the help you need. They never make you feel bad or like you're a pain or a bother to them. They're a great company. I mean, if that's the word that you use for Gilchrist,
for me.
I don't know what the word should be, but they're absolutely, I can't say enough. I don't know where I would be. If it ever comes time that you need to have services.
You sold me.
Because there's never not enough that Beverly and Gilchrist and all those ladies and all those different companies that they send here, they can't do enough for you, any of them.
We set out on the road with nurse practitioner Beverly Ruiz to learn more.
What inspired you to do, this kind of work?
When I was a nurse working on my master's for my nurse practitioner program, I worked in home health. And so it gave me the opportunity to see what it's like when someone comes home from the hospital or leaves the doctor's office with a bunch of instructions and no idea what to do with it. Suddenly it's different. It's much different when you're in a home environment. And so 5 years ago, there was a shift in the medical arena where we were seeing more patients that really couldn't get out to the doctor's offices. And that's when the geriatric practice at GBMC really recognized the need that we had to have something to bring care to the home.
And when you get a new patient or you have an established patient, I guess, what's the main thing you try to do when you visit?
So when we have a visit, we review the medications. We address whatever the need is at that time. Is there a new symptom? Is there a concern? Is there something that we have to evaluate further? Is there a need for additional services? Is there anything that we can do that would make the patient more comfortable in the home? We like to make sure too with every first visit with our patients is what are their goals of care? What is it that they are looking for? Is it their desire to remain in their home at all costs, or do they still want to have aggressive medical treatment? And what can we do to try to help them reach their goals of care?
And Darlene seemed to refer to you as a friend or a member of the family. That must happen a lot.
You tend to get, we follow patients for the most part for at least 6 months. Sometimes it's a few years that you'll get to know somebody. It just depends on where they are when we meet and what their needs are. And you do tend to feel like you're part of the family.
Is there anything I haven't asked you that you wanted to bring up?
I think that the thing that's important about this program is that we're serving a population that has a difficult time getting out. That if you can't get into the doctor's office for your medications, or you can't get in for routine symptoms that might, become a bigger problem, then people end up using the emergency room for their care. And that this program, by being able to bring all of these resources in the home, has cut down on our hospitalizations and emergency room visits and allows us to provide care to people who need it the most in their home. And that's really where they want to be.
Gilchrist Elder Care provides the resources and support you and your family need to maintain the best quality of life. From comprehensive health assessments and medication and symptom management to the little things like light meal preparation, assistance with errands, and companionship. For greater living, I'm Don Scott.
Well, that was so great to hear from Darlene, and there's your job satisfaction right there, right?
There it is.
You're a godsend to her. Plus, she got to talk to Don Scott, who I'm sure she watched for years, right, on TV. So it was probably really fun. But we got a sense of what you do, and how important it is, and how you help to create. I think we all need this. We all need a village. We all need a community, and you're such an important part of that village and community for Darlene, and we got to see kind of that in action. And I'm just wondering, as the population ages, right, you must have more and more clients, more and more patients. Is this something that concerns you as far as keeping up?
You're exactly right. We really are always struggling to keep up with the demand. We've just added 2 more providers in the month of July. I think that's really kind of part of our strategic plan to continue to assess the needs and be in a position to be able to meet those. You referenced taking a village. I think part of our program is not only our providers, they are obviously key and forefront, but also able to assist them. Really, we have social workers who are going out and doing things, for example, making sure that there are groceries and that they're able to get medications and that the electricity is able to stay on. And if they're not, they can help fill out applications. They will hand deliver. They will come back the following week. We actually work with a group of pharmacists that also do medication reconciliation, sometimes help with recommendations that then our providers work with and have a multidisciplinary team. And we do a little bit of telehealth monitoring where we're able to get some biometric feedback, blood pressures and different things that, again, our providers have a comfort level of making decisions and interventions with that objective data that they historically would not have had.
Yeah, it's so easy to run down a laundry list of things that you do provide, but once you get in the home, the little nuances, the little things that come up, you kind of jump in there too because you're there, right? And you're not going to turn down a request for help, or at least helping that person get the help that they need. I think we have a comment or a question.
No, we do. We have a comment from Roseanne, and she basically says what I'm sure a lot of people have said: Gilchrist is awesome. I'm forever grateful for what they need or for what they've done for my mom. So there you are.
Nice to hear.
Yeah,
Nice to hear.
and people will never forget that. Never. So, and let's talk a little bit about sort of the nitty-gritty of the practicalities of it. And people always bring up Medicare, what's covered, how do I work that? How do they?
So Medicare is probably the predominant payer source of the type of population that we serve, but we also work with numerous commercial payers, managed care companies, Medicare Advantage, of course, we're seeing come up more so. And then our providers bill just like if you were to go to the office, is how that billing is facilitated.
How long, I know it varies with individual, but how long can you be in the program? Is there a limit?
There really is not. What we will do is really stay with that patient until they transition perhaps into our hospice program, or maybe they move into long-term care, or if they move into an assisted living, we might be able to stay with them depending on where that is. So it really is dictated by the patient in the course of events.
Do you get involved with, I'm sure they have conversations with you, and this might speak more to you, Bev, because you're in the field more, I guess, right?
Yes.
Do you get involved in, I'm sure you do, they say, I don't want to leave my home. I want to stay here. What can I do? And you're seeing a declining patient or an individual who might need more care. I'm imagining, have had to have some very difficult conversations.
Yes. And so, we've got our resources that support us in our program as well. So maybe this is an opportunity for skilled home health, which was mentioned in the earlier segment, where we can ask for home health services through a Medicare Part A program, for example. Maybe a little physical therapy or occupational therapy, maybe an evaluation of the home and some safety bars or adjustments to the home. Making adaptations to the home will help. The other thing, though, is our social workers are just so valuable in helping patients establish connections with community resources. And maybe it's time to do some family planning as far as long-term goes. What do I need to stay in my home? What are my goals of care? Do I have an advance directive? Do I have what I need to outline the decisions that I want to make for myself while I still can? And that's where our social workers are so helpful.
Do you find that most of the time it's the patient that is still making the decisions, or is it a family member or somebody who's been sort of appointed by the individual?
It really depends on who the patient is and why we're seeing them. A patient with dementia may already have a caregiver who has to act as power of attorney. However, we may have a patient who can still make all of their own decisions and haven't yet done that, and that's an important conversation that needs to take place.
Caregivers, is there a greater labor of love? There really isn't. Anyone who's been a caregiver, who is a caregiver right now, it is wow. You're giving, and that's like the key word. It is a labor of love. It's exhausting. There are often few places, you feel like there are few places to turn.
Yes.
So I'm sure even they will talk with you from time to time about, even just to vent, right?
Yes.
Kind of.
Yes.
Yeah, I was going to say from a Gilchrist standpoint, and caregivers really is number one, right? Everyone really needs a caregiver, and sometimes we need to take care of the caregiver. Gilchrist has services. We have the bereavement and counseling, which we'll hear
They're
a little
talking
bit
about,
about.
yep.
That can speak specifically for that, but they really do have specific programs that can help at any time, designed specifically for caregivers.
If you were to just speak to the issues facing your department right now and where you see us going in the future, what do you hope happens? Do you hope more people find this as as a career? What are your needs that you see that just over the horizon that you're gonna?
We continue obviously to see the geriatric population continue to, is it 10,000 people turn 65 every day? And so, the need for the work that we do just continues to grow. The need for the providers that are interested in doing that work out into the field continues to grow. And so that, I think, is how do we get that message out? I think our Gilchrist does a fantastic job with having nurse practitioners who are in school that come and have been and had an opportunity to be with Bev and learn about the great work that we do. I think that's one of the things that we need to continue to focus on is how do we bring providers to this work.
Is that your biggest core, nurse practitioners, of people who you have in your group?
Nurse practitioners and actual geriatricians.
Okay.
For physicians, yes.
Okay,
Both
great.
greatly needed.
Yes. Thank you so much for joining us. We are going to talk about some of the bereavement opportunities and talk about palliative care, talk about hospice some more too. But thank you for the work that you're doing in helping individuals stay in their homes where they're comfortable, where they feel secure and have some control at a time when they probably feel like they're out of control, right?
Yes.
So much about their health is breaking down.
Yes.
So we really appreciate it.
Thank you so much.
Thank you.